Yeah, certainly. Thank you so much. And I apologize for all the technical difficulties that I had. And I don't have any financial disclosures. I should mention that I have 2 devices that Brain for Care has graciously loaned us for the last 2 years. And that's where most of this, or all of this research actually has been performed on. But as I said, no financial disclosures. I want to talk a little bit about what cerebral autoregulation is and what it isn't, and how we approach this and how we decided to test it with the device in question. It's important to understand that traditionally we think of cerebral autoregulation as the ability of the brain to keep a constant blood flow regardless of blood pressure changes. And that's not quite true, to be honest with you. There are some modifiers there that are important to keep in mind. You better think of it as a range of blood pressure in which variations of your blood flow in the brain is minimized during changes in perfusion pressure. However, it's not a plateau phase like the Lassen's curve would suggest. It's more of a slope, but also is strongly affected by the rate at which that blood pressure changes. So here on the left, if you have various low fluctuations in blood pressures over the, say, days or weeks, obviously your blood flow is going to remain more or less constant. However, if you have significant blood pressure variations that happen within seconds, the blood flow is going to vary in the same proportional fashion. So your autoregulation is not going to protect your safety there. The greatest example we have is this standing and sitting maneuvers where you measure blood flow and you measure blood pressure during these repeated standing exercises. And you can see that your blood flow invariably is going to drop as you stand, and as you sit down, it's going to go up. So the point being that if your blood pressure changes too quickly, your autoregulation mechanisms are going to be able to help you. So whenever I talk about autoregulation, we're talking about slow changes in blood pressure and a more or less constant CBF, but certainly not just a unique value. Now, the reason why we think that autoregulation is that important is because in patients with acute brain injuries, certainly it can lead to ischemia on the one end, or potentially edema or hemorrhagic conversion or hematoma growth on the other end. And that's for patients with acute brain injuries, but even in the normal aging process, there is now evidence that impaired autoregulation may actually be a contributing factor for things like cerebral amyloid angiopathy and potentially other types of vascular or cognitive dysfunction, I should say. The other point that I wanted to make is that when people talk about static and dynamic autoregulation, it's important again to realize that what we're measuring at the bedside currently with the technique that I'm going to show you is more of a dynamic process. The static, anyway, is sort of the older concept that I think is helpful to understand what autoregulation is all about, but not really, doesn't really resemble what we see at the bedside. To talk about autoregulation, I think it's always important. I love history, to go back a little bit in the history of monitoring ICP. And this is from the original Lundberg paper back in the 50s when he first started recording ICP waveforms. And he described a number of different waves. And in particular, we focus on B waves. And the reason we focus on B waves is because they are believed to be sort of the substrate for autoregulation. And they are, just so that if people who may not be familiar with them, there are these slow wave fluctuations that happen over time. The frequency is really low, as you see there, and they are associated with vasoconstriction and vasodilatation of the cerebral vasculature, which are thought to be part of that autoregulatory response. But there is a different type of B waves that have been described, either ramp or sinusoidal type of waves. And the sinusoidal in particular are the ones related to autoregulatory changes to arterial blood pressure. The other thing that is important to realize that when we say B waves, we're talking about compressed recording. So instead of the normal or regular ICP waveform you see beat to beat, we're talking about compressing that over a period of time. So as I mentioned, those B waves reflect changes in cerebral blood volume, vasoconstriction, vasodilatation. The generator, the engine for those waves is thought to reside in the vascular control center of the brainstem, and that's actually quite important as well. And they carry information on brainstem function, but also a little bit on compliance and cerebral autoregulation. And I have some other data on compliance that I want to share with you. And the previous speaker was talking about compliance. I'm happy to see that it's not just a couple of us who believe or like this compliance concept, but there are other people in the world who actually pay a lot of attention to this. There are some B wave surrogates, so you can capture something that looks like a B wave fluctuation on TCD, transcranial Doppler of the middle cerebral artery, and also on near infrared oximetry. So this phenomenon is replicated at various levels. But we also know that B waves can be absent in certain patient populations with acute brain injuries, primarily TBI, subarachnoid, and ICH, and also that the absence of these B waves correlates with poor outcome, presumably because of impaired autoregulation and secondary brain injury. So the first question that we asked ourselves was, can we measure or can we evaluate the presence of this slow wave activity of the ICP following patients with acute brain injury? And if we can detect it with Brain for Care, can we validate it with the invasive monitoring that is being established and well described and see how well the two of them correlate? And that's exactly the first step that we did. So we have a multimodal monitoring database. We monitor patients with acute brain injury using the ICM Plus platform, save that, and then retrospectively, a period of about 3 months, we decided to go and look at what we had. I'm reporting here, or I'm presenting here 10 patients. We have now close to 30 patients, but the results remain to be quite consistent. These were patients who had an external ventricular drain for continuous ICP monitoring, but also we then attached the Brain for Care device for non-invasive ICP waveform monitoring. And we continuously collected the data, as I mentioned. I'm not an engineer, won't pretend to be one. That's the analysis that, waveform analysis that we did, and we had Danilo Cardin's help to be able to do all this detrending and the power spectral analysis, etc. So kudos to him for helping us accomplish this. What I do want to show you, though, this is an actual example from a patient. This is a fast Fourier transform, and here you have the amplitude of that ICP waveform. In green, you have the invasive recording, and in red, you have the non-invasive recording. As you can see, the Brain for Care device is able to capture these changes in amplitude at different frequencies. And if you look here on the upper right-hand corner, that's an actual recording from Lundberg, and you can see that he had already identified the slow waves, the respiratory waves, pulse waves, very similar to what we're able to record. More importantly, the non-invasive ICP, the Brain for Care device, is able to capture exactly the same amplitude, exactly the same frequencies as the invasive device can. More importantly, this is just a repeated measures correlation graph looking at ICP slow wave amplitude, so invasive on the x-axis and non-invasive on the y-axis. And as you can see, very, very good correlation between the two, meaning that we're able to detect those B waves with the Brain for Care device, but not only can we detect them, we can actually measure changes in that amplitude over time, which is actually quite relevant, as I will show you in a little bit. So we concluded that yes, we can detect them, and it's interesting that we can do that. It's statistically significant. You know, what are the potential clinical applications of B waves, right? Most people don't go to the bedside and say, what are the B waves of these patients, and I'm going to change therapy based on that. So, and the clinical relevance for us really is that it's a precursor for being able to monitor cerebral autoregulation. This is a meta-analysis. I won't spend too much time on it, but I just wanted to show that cerebral autoregulation actually is sort of a trending and hot topic now in neurocritical care. In this meta-analysis, they look at patients with ischemic and various types of hemorrhagic strokes and trying to see what the literature has on autoregulation. And as you can see, there is a number of reports that show there is impaired autoregulation, and that impaired autoregulation actually can correlate with outcomes in many of these patients. More importantly, this is from a group at Yale University. They looked at patients who underwent thrombectomy for acute ischemic stroke, and they used an autoregulation guided approach to look at blood pressure. What they found is that patients who spent a significant percent of time above the upper limit of autoregulation had a worse functional outcome. Their MRS trended higher. And not surprisingly, that worse outcome because of spending time above the upper limit of autoregulation was driven primarily by hemorrhagic conversion. So symptomatic hemorrhagic conversion of that recanalized blood vessel presumably because you're above the limit of where the cerebral vasculature can handle the blood pressure and the blood flow that territory is in, and that led to hemorrhagic compression of those strokes. Similarly, there is a very strong literature on trauma, so much so that there is an ongoing trial, feasibility trial, looking at autoregulation guided cerebral perfusion pressure after TBI. The Yale group that I showed you earlier is actually obtained funding to look at autoregulation guided management of blood pressure after mechanical thrombectomy. So the concept or the idea is that you can generate a curve of ideal mean arterial pressure that is driven primarily by an autoregulation index. So that's to say you're able to identify the blood pressure below which you're under the lower limit of autoregulation, and presumably that would lead to increased risk of ischemia, as you see on your far left. On the other hand, if you're above that upper limit of autoregulation, then you're going to see potentially problems like cerebral edema, hemorrhage, etc. And more importantly, we'll give you what the sweet spot is, which in this case is about 95 millimeters of mercury. So you have a nice range where to keep your blood pressure and minimize secondary brain injury, at least in theory. Now, the current technology to assess cerebral autoregulation has some limitations. For example, ICP waveform, which is the gold standard, without a doubt, is invasive. So not all my patients actually have an ICP waveform invasively. And there are patients in whom you don't want to drill a hole to get a bolt. Similarly, if you wanted to study this in astronauts, as we were hearing before, you wouldn't be able to drill a hole in space and put an invasive ICP, right? You can use cerebral oximetry, again, Lycox here in the US, invasive device. You can do transcranial Doppler, and it works relatively well. However, you need to find a cranial window. The angle of insonation has to be kept constant, and it's going to affect the velocities, and that's a very tricky thing to do. And then it's really not, I'm sorry for the typo there, it's very difficult to do prolonged monitoring with transcranial Doppler to keep it in place so it doesn't move and it's not subject to artifacts. Near infrared, there are a lot of assumptions you make. You rely on the constant hematocrit, SADS, and cerebral oxygen metabolism, which in patients with acute brain injury, that's hardly the case. And then the other problem is you have a lot of skin contamination, right? So you have the extracranial sort of external carotid circulation between the sensor and the brain, and you're going to pick up some of that signal invariably, and that can throw off your assessment of autoregulation. Furthermore, when you look in the literature at the agreement between invasive and non-invasive indices of ICP-derived autoregulation, their agreement at best is modest. It's certainly nothing to write home about. When I talk about ICP-derived indices of autoregulation, there primarily have been three described: the pressure reactivity index, which correlates the slow wave fluctuations in the ICP, in the actual pressure, and the mean arterial pressure; the pulse amplitude index, which correlates the pulse amplitude of the slow wave fluctuations of ICP and mean arterial pressure; and the RAP. We decided to focus on the pulse amplitude index because, as you know, getting pressure from the brain for care sensor, at least for now, is not feasible, although I have something to show you at the end. But certainly the amplitude of the waveform, if the recording is left alone and things are the same, that amplitude is we think is gonna correlate quite well, and that's part of what the B wave experience showed us. So we focus on the pulse amplitude index, which has been well validated in a number of different patient populations, and in fact has been correlated with outcome, not only in TBI, but also in patients with perihematomal edema. So we know it's a validated index of autoregulation derived from ICP waveform. Here, again, just to highlight that there are different thresholds that have been described that correlate with favorable and unfavorable brain outcomes in patients with acute brain injuries. So then we analyzed our experience for the last year in 2021. We identified 24 adult brain injury patients that had both an external ventricular drain and a brain for care device, continuously collected data. They also needed to have an arterial line so that we could obviously get information, continuous information about MAP, and be able to build PAX and non-invasive PAX. Very similar to the B waves, we used ICM Plus in our studio to conduct our analysis. To give you a little bit of clinical background, the median age or the median age was 53.5. Most of them had intracerebral hemorrhage. 87 were undergoing, 87% were undergoing mechanical ventilation at the time of the recording. 60% of them were sedated at the time of the recording, and the median GCS was 8, with the interquartile range as depicted there. This is some monitoring data. So the median time for monitoring was about 40 minutes. You have the median arterial blood pressure there. But what I really want to focus your attention on, look at the invasive PAX. The mean was 0.02. And when you look at the non-invasive one, they were very, very close, 0.017. So the difference between the two was really minimal. More importantly, we perform a Bland-Altman plot for agreement, really considered to be the gold standard of a statistical test to look at agreement between two tests. And we found excellent agreement in terms of invasive versus non-invasive PAX. So much so that the statistician actually didn't believe us at first that we were using two separate devices, and linear regression, again, showing a very, very strong correlation between invasive and non-invasive PAX. So we concluded that yes, we can detect it reliably using the novel non-invasive ICP monitoring. And then obviously we want to now take the next step and see how we can use PAX and use an autoregulation guided management of blood pressure in different patient populations, because we have a lot of hemorrhagic stroke. That's the population we're focusing on, and that's sort of the next step for us. I want to show you two things quickly and then open it up for questions. I said something about compliance. We have right now another ongoing project where we're combining Brain for Care with transcranial Doppler ultrasound. We submitted our preliminary findings as an abstract to the Neurocritical Care Society meeting, so hopefully it will be presented there. One of the ways one can calculate compliance is looking at the fundamental amplitude, the change of the fundamental amplitude of the cerebral arterial blood volume, which you can substitute using transcranial Doppler ultrasound. So we do TCD on our patients, and then we look at fluctuations on that and fluctuations in the fundamental amplitude of the ICP waveform, for which instead of using an invasive device, we're using the non-invasive Brain for Care device. So we calculate compliance with TCD and invasive on the one hand, and then we calculated with TCD and non-invasive, same patient, same time, and the correlation of that compliance estimate, again, is extremely good. We're very impressed with the type of correlation we're getting. So I know that there are other ways people estimate compliance. You guys talk a lot about P2, P1 ratio and time to peak. There are potentially some difficulties. Some of them you have to guesstimate based on arterial waveform. You may not necessarily identify. It's good to have more tools in your toolbox. So if for whatever reason you don't believe the P2, P1 ratio or time to peak, you can always default to combining transcranial Doppler and Brain for Care and still be able to trend compliance over time. Again, to the last speaker's point, I think I care more about compliance oftentimes than ICP, to be honest with you, and I want to be able to measure and trend it in my patients. So maybe taking a transcranial Doppler ultrasound in space travel is not as easy, but maybe it can be miniaturized somewhat. Last point, we looked at patients with, what you see here in blue is arterial waveform recording. What you see in orange is invasive ICP. And what you see in green is the Brain for Care device. And what we're trying to do, working with some computer scientists, is to create an algorithm that, if given the Brain for Care waveform and given the arterial waveform, can we estimate what the ICP is? When can the computer guess what the ICP is? So we're not quite there yet. The computer still needs calibration. That's to say, it needs to know from the invasive device what the ICP is. And once we tell the computer what we calibrate it and tell them what the ICP is, it actually is within a few points. It tends to maybe underestimate it a little bit, but we're under a couple of points from true ICP. Of course, the holy grail would be for us to be able to just use a line and to use Brain for Care and tell you what the ICP is and have a good correlation. We're not quite there yet. Our guys are optimistic, but we're still working on this. So hopefully next time I'm invited to speak, I'll be telling you about an algorithm that we developed that using Brain for Care and A-line is able to get really close from telling you what the patient's actual ICP is. And with that, I want to acknowledge the people that have contributed for this studies. Katie Hassett, my fellow, who's going to come join us as a staff. Danilo Cardin from University of Texas. Statistical support, Dr. Moore from neurosurgery, and everybody here in the neuro ICU at the Cleveland Clinic. Thank you very much, and happy to take any questions you may have.
Dr. Gomes, Dr. João Gomes, it's a great pleasure, and I appreciate that you really try to present your nice data, very nice talk, and I think that's a very good opportunity to ask you about how the non-invasive, how the brain for care system for non-invasive would be helpful and differentially in terms of having a nice data, nice waveform, and nice idea about the brain compliance. So could you tell us about your experience on the day by day?
Yeah, absolutely. I think what we have found is by probing different aspects, right, including B waves and PAX, etc., we found that there is significant reliability between the ICP waveform that we obtain by non-invasive methods, brain for care, and the invasive methods that we have at our disposal. So they seem to correlate quite well. The changes seem to track and follow each other quite well. And where we see a lot of potential applicability, obviously, is not to replace ventriculostomies, right? If you need a ventriculostomy, you need a ventriculostomy. But it's actually extending this technology and this way of thinking into patient populations who traditionally we are not able or are not good candidates for a ventriculostomy. So another patient population that I deal with a lot is patients with acute liver failure who develop a cerebral edema. But they are coagulopathic, so we don't want to go and be drilling holes in their head to put an invasive ICP monitor. But also, there are patients that you may want to monitor and look at compliance. For example, idiopathic intracranial hypertension, venous thrombosis, acute strokes who are at risk for developing malignant MCA syndrome, brain tumors, et cetera, et cetera, et cetera. And the other thing is that obviously I'm a neurointensivist, so I work in an ICU. It doesn't have to be restricted to an ICU. This is something that you can take to your clinic, and you see somebody with, let's say, headaches, and you're concerned about potentially they have some intracranial pressure elevation or poor compliance. We could very easily potentially use this device to look at their compliance and enhance your bedside assessment. Again, I don't think it's going to necessarily replace. I think it's going to enhance. And it's going to extend this monitoring to patients who currently are not good candidates for it.
Yeah, very exciting and promising data and work. So did you study also brain for care's capability of identifying intracranial hypertension? So do you believe it can become a screening device?
I think so. I mean, I still think there is some more research to be done. As you saw, what we have is 20 patients, 30 patients, so still relatively small numbers. Hopefully that is going to explode soon as it becomes more available. But our preliminary experience is very encouraging. And I like, in particular, the combination of it with other technologies. So because now I have transcranial Doppler, which is easily accessible, and I have brain for care. So two different technologies, two different ways of probing and assessing the brain. And particularly if they both are in agreement and they point in the right direction, to me, that's even more powerful. So yes, I believe that, and I'm salivating over the idea of potentially using machine learning to be able to create a way to get close to a number. So we're not quite there yet, but I'm optimistic.
Yeah. Yeah, I mean, that's fantastic. I think another question I have, so since you have patient treatment, so have you tried or have you been experienced to give some drugs, for instance, the antihypertensive drugs for somehow, maybe the patient is not hypertensive, but let's say the angiotensin blockade for like losartan in your experience. So have you tried or have you seen any effect of that straightforward in the brain in terms of changing the wave or ameliorate the wave or changing intracranial pressure in somehow?
Right. Yeah. So right now, all of our research is really observational. The platform we use, ICM Plus, doesn't have FDA approval. So therefore, it's just something that we monitor and collect, and then we do retrospectively go back and look and analyze. So we have to be very careful. As I said, those platforms are not FDA approved yet, so they should not be used for patient care just yet. And I'm not talking about the Brain for Care, because I know you guys have FDA approval, but we're talking about the analysis platform that we use. Nonetheless, we've captured a couple of patients that happened to have the device and had some increase in intracranial pressure. We use a 23.4 saline infusion, and you definitely see the changes in the P2-P1 ratio, you see the changes in the amplitude, and you see it both invasive and non-invasive. So that's what I meant when I said that they do sort of reflect and follow each other quite nicely.
It's lovely, great, yeah. I think we now have to change for another presentation. We are exactly in the precisely time. Again, Dr. João Gomes, I appreciate your talk and your time with us, and I think we have a very nice collection of your working right now in Cleveland, and thank you very much.
Thank you for the invite, and sorry again for the technical difficulties.
No worries, that was perfect. Thank you.